Good morning, everyone. And as you can see, one of the great things, one of the great qualities and benefits that we have in the Cambridge Africa programme is to be led by someone as outstanding as Caroline, who's really brought vision and quality and determination and drive to the overall programme. So it's a great pleasure to chair the opening session today, part of the Healthy Futures programme, where we are looking at lung health in Africa. We've got three speakers. They're going to speak for different periods, and then we will have a question and answer session for all three of them afterwards, because I think it's the multidisciplinary interaction between the quite different talks that they are going to be presenting that I think is going to be a really rich part of the programme as a whole. However, the first speaker this morning, and it's a great pleasure to welcome Professor Refiloe Masekela, who's going to speak about lung health in Africa very generally. Refiloe is an associate professor at the University of KwaZulu-Natal in South Africa, obviously. She's a paediatric pulmonologist and the academic head of Department of Pediatrics and Child Health at that university. She's also president of the Pan-African Thoracic Society, and through that work she does fantastic capacity building work with the PATS-MECOR program that she also directs. Her work is internationally recognized, and she's an NIHR-funded professor in global health, which is a very high bar to receive that sort of funded position, and it's a great privilege to have her here before. In terms of to have her here today. In terms of the capacity building program that she directs, she has that program, the PATS-MECOR program, has trained over 300 participants, developing research skills on African respiratory ill health. Refiloe's particular interests are studying asthma interventions in children. And she was actually the first LMIC-based researcher to be awarded an NIHR Global Health Professorship. It's a great pleasure to welcome Refiloe to the podium today to give the first keynote speech on lung health in Africa. Thank you very much. Thank you.
Thank you. Thank you very much for that very kind introduction. I promise dancing was not part of the deal. Okay, so we'll just wait and see if we can get the slides up. I would be very happy to dance to an African song, but I'm sure that we'll be able to get something more suitable. So while we're getting the slides up, I just wanted to say thank you very much to Caroline, to Karina for the very kind invitation for me to come and speak today. I think when they asked if I could possibly come here, it was without any doubt that I would be very happy to come and join today. And as the introduction has said, I think I'll just give you a brief background about the PATS-MECOR program. This gives me time to save time in my slides. So the PATS-MECOR program was actually started. It's part of the American Thoracic Society program. It's a worldwide program. It's run in 7 continents, and the African continent was actually the second continent that joined after Latin America. The program has been running now. We've celebrated 30 years of MECOR, and Africa is in its 22nd year of the MECOR program. And really, this has been transformative. I was actually one of the trainees on the MECOR program, so you can see that we do have some good products from the program. So is it fine? Can I get started? Yeah. So firstly, I just wanted to say I really have no conflicts of interest with regards to the talk today. And I thought what I would talk about today, because I'm aware that we have a very diverse audience that I'm speaking to, I would just briefly touch on what are the biggest threats to lung health in Africa today. We have 2 colliding epidemics, and that's one of really acute respiratory infections as well as non-communicable diseases. I'll talk a little bit, touch on the determinants of lung health. I'll speak about what I think are really the key respiratory infections that really influence outcomes. And then I will touch on a project that we're working with that was partly funded by the Albarada Foundation on chronic respiratory diseases in Africa called Chest Africa. So really, as I've mentioned, in Africa we have really two big lung health challenges. One is from the really big three infections: HIV, TB, malaria, and of course the issue of non-tropical tropical diseases that are really neglected. And these infections actually are the biggest killers on the African continent in terms of lung health. As we well know, HIV burden in the world, the highest burdens in sub-Saharan Africa, and it's intermittently linked with TB infection. But linked to that, communicable diseases, non-communicable diseases are actually on the rise in Africa. By 2030, non-communicable diseases are set to overtake respiratory infections as causes of death in Africans. Now, the top four non-communicable diseases is cancer, diabetes, cardiovascular disease, and chronic respiratory diseases amongst the top four non-communicable diseases, and these cause almost 2 million deaths worldwide every year, premature deaths, and about 2/3 of these are related to these top four non-communicable diseases. If you look at the slide, which is from the Africa CDC, if you look at the red bars really depict non-communicable diseases. You can see that from the 1990s through to 2019, there's been a steady rise in the non-communicable diseases, and as I've said, by 2030, these are set to overtake respiratory diseases in terms of, communicable diseases in terms of causes of mortality. But when we actually look at respiratory infections, Africa, the highest burden of mortality from pneumonia is actually in young children under the age of 5. Now, despite our wonderful gains from vaccines like pneumococcal vaccine, which has really saved many, many lives worldwide, in Africa, by 2019, pneumonia was still the biggest killer of children. You can see that from the 1990s through to 2019, still a huge proportion of children were being killed in Africa by pneumonia, an infection that's easily treatable, that's easily managed, but unfortunately on our continent, it's still a really huge challenge and a big killer in young children. Now, why are children in Africa still dying from pneumonia? The reasons are multiple, but they're also quite simple. We know that if people don't get good access to treatment early on to manage a pneumonia, this is where we get the majority of deaths. We know that if health systems are not strong enough to be able to have the capacity in terms of diagnostic tools to pick up infections and treat them appropriately, children will die. But there's also other very important factors that are all socio-economic determinants. This is data from the Global Burden Disease. This is for children that died from pneumonia in my country, in South Africa. And when we really looked at what were the most top 3 risk factors for death, child wasting, which is really linked to malnutrition, so poor nutrition, so poverty. Children that are born light at birth, low birth weight. And we know that in the African context, if mothers do not have good access to antenatal care, they don't have good maternal nutrition, they don't get a good diet, that they're at high risk of having early deliveries, premature deliveries, as well as pregnancy-induced hypertension, which results in lighter babies, and these lighter babies are then at risk of future death from pneumonia and other factors that I'll discuss in a little bit. So again, it looks like factors that are responsible for children dying in Africa are to a large extent preventable. Now, if we look at the non-communicable respiratory diseases, and here I'm talking about the 2 big common non-communicable respiratory diseases. Here we're talking about asthma as well as chronic obstructive pulmonary disease, which is COPD. The estimates of people dying from these two diseases in Africa, this is data from the WHO, almost 200,000 people every single year are dying from these common conditions. Now, if we talk about asthma and asthma deaths, we know that most people in high-income countries, for example, in the UK, are not going to be dying from asthma because asthma has, there's good drugs to manage asthma. But in Africa, where the majority of countries are either low-income countries or low-middle-income countries, people are still dying from these conditions. So what are socioeconomic determinants of death, of health? Now, poverty, so a family income is a huge determinant of how people will either survive or die from disease. We know that if we look at the WHO setting for poverty, the poverty line according to the WHO is a family that earns an income below $2.17, that lives on below $2.17 per day. But if you look at a country like Ethiopia, what is actually regarded as the poverty line is about $2 and about 7 American cents. This is, if you compare this to someone who's living in the US, the poverty line is almost 20 times that of somebody who's living in Ethiopia. So poverty in itself is really a huge determinant of outcomes, whether people will live or survive from disease and what sort of outcomes they would have. Of course, ethnicity or race is an important determinant. Transportation linked to pollution, community infrastructure. We know people that are living in old buildings, mold, etc. This will influence outcome, the type of housing they have. And of course, as I've talked about food, we know that children that are malnourished or have stunting are at higher risk of death from infections, as well as I've just demonstrated. And also, the level of education, particularly so maternal education, is a huge determinant in terms of outcomes. So who are the vulnerable people in our populations? So usually your marginalized people who are really from a migrant community or minority communities. Children and as well as the elderly are usually the most vulnerable in the population in terms of risk from death, from pneumonia, for example, because they have a more weak immune system, so they're at higher risk of death. And also people who live in low-income communities. I think there's also disparities, not only in low-middle-income countries like Africa, but also in the UK, where people that are from more low-income households, there's also disparities in terms of health outcomes. Now, this slide is to just demonstrate. We know that in terms of lung health, what lung capacity you're born with, you will generally track that lung capacity throughout your lifetime. Now, for babies that are born lighter, that are premature, they normally will have a smaller lung capacity compared to those that are born at a normal, at term, or and so they already start off at a negative. Now, there is sometimes capacity for people to have what we call catch-up growth, and that is a possibility for some people. But if you start off small, and for example, you reach your mid-adulthood, and you have excessive exposure to harmful substances such as tobacco smoke, etc., you will have a much faster decline in your lung capacity compared to your peers. So unlike what Hollywood would like us to know, 40 is not the new 20. In terms of your lung health, everything is wonderful until you reach the age of 20, and then it's all downhill from there. So then it's really important, as I've discussed, children that are starting lighter and they have a lower lung function, these are the people who are going to be at risk for developing COPD later in life and also premature death. So it's really important that these issues are tackled to prevent more mortality later on in life. Now, this is just data from the Generation R study. This is not data from Africa. It's from the Netherlands, where they had enrolled mums in their second and third trimester of their pregnancy in just over 5,000 children. And they tracked these children throughout life and up to the age of 10. Why I'm showing you this is to just demonstrate that if you are born lighter, that is, you're fetally restricted, you were small while you were in utero and when you were born, this is just showing, this is a 0 line, the Z-score, anything low, it's below what is expected, above is normal. So you can see that babies that are born with smaller lungs that are more restricted at birth actually have a low lung capacity. And as I've just showed you the previous slide, these are the people that are then at risk of getting COPD later in life. So let's just change track now and talk about respiratory infections. As I've told you, pneumonia is the biggest killer of children under the age of 5 in Africa. And what causes these deaths? The most common cause of pneumonia in all over the world actually is usually your viral infections. Your respiratory syncytial virus, which is called RSV, is actually the most common cause of viral infections, and it still accounts globally every single year. Almost 600,000 babies die from this RSV infection. Other viruses like influenza, etc., are also causes of pneumonia. But there's also bacterial infections that are also common that cause pneumonia, Streptococcus pneumonia, Haemophilus. And of course, in the context of Africa, we should talk about tuberculosis. So, respiratory syncytial virus, which is RSV, as I've told you, is the biggest killer of pneumonia in children. But if you look at these deaths, almost 100% of RSV deaths happen in low to middle income countries. So you can see that although it is a very common cause of infections in children, RSV, the mortality burden lies in low middle income countries. This is data from the hospital where I work, Albert Luthuli Hospital, where one of my master's students, Prashen, actually looked at children that were admitted to an intensive care unit where we worked to see what were the most common causes of these children coming into the ICU. You can just see here the largest proportion, 50% of all children that were admitted to our ICU actually who came with a pneumonia, the cause of the viral pneumonia was RSV. So demonstrating that this infection is the one that causes the most severe pneumonia and results in children landing up in the ICU. But when we also wanted to see who were the children that were at risk for coming, again, those children that were premature or had chronic lung disease of prematurity were the ones that stayed in the hospital for longer, that required more ventilation in ICU. And as we know, in Africa, access to intensive care units is highly limited. In Africa, in some countries, an ICU is just a bed with oxygen piping. That's all that ICU means. And this is in a setting where we actually have a highly facilitated ICU. And you can see that, for example, if you're a child who really requires ventilation and in Africa, you probably won't access it. And that explains why RSV is still accounting for so many deaths in worldwide every year. So these are just a number of studies that have just looked at RSV and outcomes in children who are infected with RSV. This data on the left side is from the Drakenstein childbirth cohort in Cape Town from Heather Zah's group, where they followed children, maternal child pairs, over 1,000 mothers that were recruited in pregnancy, followed up these children for the first 5 years with sampling whenever the children had a respiratory tract infection. And what they found in the study, that all those children that had at least one RSV infection, when they did lung function testing serially up to 5 years, these children had significantly lower lung function. So even if they started normal, they dropped off, as I showed you. So RSV is then an important determinant in terms of long-term outcomes, because these children already show decline in the lung function from having had at least one RSV infection. This data is from the two-son childbirth cohort based in the US. This was a long-term cohort. People followed up also from birth up to their 4th decade of life. Similar findings, having had a previous RSV infection predisposed these individuals to having more asthma later in life and having lower lung function. Similar data from the US, and also this is data from Charles Verwey's group in Johannesburg, where they also followed up babies that were admitted with severe viral pneumonia due to RSV. Again, these children that had RSV had much lower lung function when they were compared to those who didn't have RSV. So RSV is an important virus that needs to be targeted if we're going to prevent pneumonia deaths. This is just to show you a snapshot of what is in the vaccine pipeline. We have wonderful new developments, exciting in the last few years in terms of access to newer monoclonal antibody vaccines. Now, these vaccines are available and are already being given in many high-income countries, and they are very, their efficacy is over 70%, so they're very efficient in preventing RSV. But of course, all this comes back to dollars and cents. We know what happened with the COVID vaccine pandemic. The vaccines were available, but many LMICs, especially many countries in Africa, didn't have access to these vaccines. So what about RSV vaccine, the new vaccines that are available? This is was a systematic review and meta-analysis looking at the cost effectiveness of these interventions and how cost effective they would be to implement in low to middle income countries. And in this systematic review, they managed to find 19 studies, but if you look, most of the data was actually from upper middle income countries, only 4 from LMICs. But what was really interesting to see, if these vaccines were given at a population level, would they be what would be the ISAs, what would be the benefit of giving these in terms of different settings? What was very interesting was, depending on the country income, the ISAs are hugely different. You can see all these dots, very different depending on where you are. So what this highlights to me is a worrying thing. We know that in Africa, at least in terms of data capturing, health systems being able to quantify burden of the disease, it's going to be a challenge because most countries don't even sample people who have infections. So it will be very difficult actually at a policy level to be able to say to policymakers this vaccine would actually be very cost effective. But quite interestingly, Gavi has done some cost-effective analysis, collected some cost-effective analysis data, and it showed that at least in some of the 4 LMICs where this was done, it would actually be beneficial. So we hope that this can be then used for policymakers to really recommend for use of the vaccines. I can't talk about Africa without talking about TB. We know that TB is a common killer. It kills over almost 1.5 million people worldwide every year, and most of these are in low to middle income countries. Now, of the top 50 high burden TB countries, Africa has 30 countries in those top 50 high burden countries. Despite TB being a big infection and a killer, we now know that post-TB lung disease and morbidity from other end organs is also an important determinant of future health outcomes. Now, this is data from Diane Gray from Cape Town, where they actually looked at children that were admitted between the ages of 5 and 15 years who were diagnosed with TB. They followed these children up and looked at their lung function, comparing those that had TB and those that did not have TB LRTIs. And what you can see is that those children that had confirmed TB, this is the lung function test on the x-axis, and timing over months from 0 to 12 months. And you can see when these children were actually tracked, those that had confirmed TB had lower lung function compared to those that did not have tuberculosis. So TB does have impacts in terms of future lung function because it does cause a decline in lung function, at least in this child cohort. Elizabeth Malecho-Bimbo from Kenya also published a systematic review. This included adults and children, showing that people who have post-tuberculosis, most people, 40%, would have persistent respiratory symptoms. In terms of abnormal lung function, almost half had abnormal lung function after TB, and over 2/3 actually had abnormal chest x-rays after TB. So now we do know that TB does cause significant long-term impact in terms of respiratory health beyond the infection itself, even after microbiological conversion. This is Kariso Machakana, who's actually our ID fellow who I'm supervising from Botswana. And we wanted to see in these top 50 high burden TB countries, which TB guidelines or protocol actually had a mention of the word post-TB lung disease. And we looked at any protocol that included children. Most protocols did actually, we only found 40 in the top 50 countries. Most of them had some sort of statement about what happens when you have recurrent TB, how it should be handled. Very few, 9 of the 40, 22% actually mentioned anything in terms of a differential diagnosis. But our primary question was there any mention of post-TB lung disease? Of the top 40 countries that we looked at, only 3, which was Kenya, DR Congo, and it was Kenya, DR Congo, and Uganda, had the mention of post-TB lung disease in their guideline, and only 1, which was the Kenyan one, so Wanjiku should be proud, actually had a more extensive description of what that meant. So finally, what about chronic respiratory diseases? We, as I've talked before, asthma and COPD are the most common non-communicable respiratory diseases. Asthma affects 1 in 10 children, and COPD also affects about 1 in 10 adults. So these are common diseases. In terms of global asthma deaths, this is data from WHO. You can see here that dying from asthma is a problem only in low middle income countries. In high income countries, due to good access to drugs that have been really available for over the last 50 years, inhaled corticosteroids, nobody really should be dying from asthma. But if we look in terms of countries that have access to medicines, so this was a WHO country survey that was done in 2021, where they surveyed only the facilities, government facilities, to see which facilities actually had these very basic drugs. As I've told you, an inhaled steroid is a basic treatment for asthma. In low-income countries, only a quarter of all the facilities that were surveyed actually had an inhaled steroid available to treat asthma. And if we look at what is the combination drug, which is budesonide formoterol, this is a drug that is currently the standard of care for anyone who's in a high-income country. The Global Initiative of Asthma recommends this drug as a first drug that should be used in the very first step of asthma treatment. If you look at low middle-income countries, low-income countries, only 7%, and only a quarter of low middle-income countries have these drugs available. So it's not surprising that we're still seeing deaths from these in low middle-income countries. This is data from Marie Stolbrink, recently published in Thorax, where she wanted to look in 60 LMICs around whether short-acting beta agonists as well as the inhaled steroids were available or affordable, most importantly, in terms of people having access to the drugs. You can see that this is the African continent. Most countries had the drugs available and affordable, not many. And in yellow is the countries where the drugs were actually not even available. And this is the inhaled steroids. Availability only really in about 5 countries in Africa. And if we looked at drugs being unavailable, these are the orange centers. So in many countries in Africa, the inhaled steroids were not even available. But if they were available in yellow, they were actually not affordable. That is, they were costing more than 1 month's daily wage for the individual to be able to access the treatment. So I said I will talk about a project that we're doing that was funded partly through the Albarada Foundation, which we call Chest Africa. And what this is a chronic respiratory disease observatory for Africa. Now, what we've done is myself and Professor Kevin Mortimer decided to start this project, and we used the trainees that we had from the PASMICO program. So we wanted to start this observatory and to collect data in about 10 African countries. And we wanted to collect disease burden data on both asthma as well as COPD, and to not only quantify burden of disease, but most importantly, also determine what are the determinants of outcomes by doing some pulmonary function testing, collecting data as well in terms of health economic costs of drugs in the 10 countries. We now have data from 9 sites because one of the sites was Sudan. So as we know, there was a war there, so we couldn't collect data on there. And this is actually a few of the sites where the data was being collected. So what we have at the moment, and we hope that we'll be able to wrap up this data collection by the end of August. We've collected data from DR Congo, Nigeria, Uganda, and Ghana on asthma in children. You can see this is 2 cohorts, 13 and 14 and 16 to 7 years of age, using the GAN methodology to collect the data to determine whether these children have asthma. We've managed to actually complete most of the recruitment. I think in Uganda they're almost halfway, and we hope that next year, Caroline, you'll invite us to share the results. And in terms of COPD, we've got 5 centers that are collecting COPD data. In the COPD site, we're only collecting from 600 individuals per site. 2 sites they actually completed. I checked this morning, and 3 of the sites are still actively recruiting at this stage. And these are the countries where we're collecting the data from. Now, I can't talk about chronic respiratory disease and not talk about the really important impact in terms of air pollution and its and lung health. We know that air pollution actually predisposes people to lower respiratory tract infection. And if you look at this U-shaped curve in terms of mortality linked to air pollution, you can see children as well as the elderly, as I've showed, are the most vulnerable to the health effects of air pollution, and they're at higher risk of dying from it. Now, we were part of a study that was an NIHR-funded project with a principal investigator as Jonathan Grigg from Queen Mary University, where we wanted to see in children who have asthma that we identified in a larger project, what are the exposures in terms of air pollution. And these children were all asthmatics. They were all given this backpack with a GPS monitor, and we could track these children over a period of a week whenever they had the activities, from going to school, living their lives, and we could really see what sort of exposures they had. And what we found, that in terms of exposure to PM 2.5, a lot of these children in all the countries that we looked at, this was Malawi, South Africa, Zimbabwe, Ghana, Nigeria, and Tanzania, they were all exposed to pollution levels that were way above the WHO cutoff. And quite interestingly, what we also found, which was from an intervention perspective would be highly useful, is those children that were at schools where there was a lot of dust, not paved, the exposure levels were much higher at school compared to where they were on their commute, as well as when they were in their household, even in households where they were using burning fossil fuels for cooking. And really, that, I think, from a policy perspective, is something that could be easily translatable to prevent high exposure levels. But in other countries, this was our own data from Durban in South Africa, we found that despite most people having access to electricity, their children actually had high exposure levels when they were actually in their homes at night. So that also brings a new question as to what we need to look at in terms of interventions. So really, I'd like to conclude that Africa has a double burden of disease. We have communicable, non-communicable disease to deal with. Respiratory infections are still a common cause of death. And chronic respiratory diseases are under-researched, and we hope that our African Disease Observatory would really offer some solutions to address this. And I think it's really important that with all our research, we really build in the health economics so that we can really build some good arguments for our policymakers to ensure that there's access to preventative treatments as well as effective treatments. I just wanted to leave you with this slide. I think the next, which is actually not the next, it's already happening, climate change is a big risk for Africa. This is photos on the left. It's when there was a Kenyan flooding a few months ago. And this photo was actually taken about 15 kilometers from my house in Tongat in KwaZulu-Natal about 2 weeks ago, where we had a tornado. We've never had tornadoes ever in our country. And I think we're going to be facing emerging infections. We're going to be facing new challenges if we don't work on climate change and try to address this in the future. I'd just like to thank all of our collaborators as well as our funders for all the work.
Thank you very much indeed to Professor Masekela. So as I said when we introduced our first of our keynotes, we're going to have 3 talks in this session, and then we'll have the questions and answers afterwards. So please do store up your questions, write them down if need be, to make sure that not all of the questions are focused on the third talk. That's really important because there are so many really interesting things to ask about. It's a great pleasure now to introduce a second speaker of 3 in this session, as Dr. Gabriel Okello. Gabriel is a Prince of Wales Research Fellow at the Cambridge Institute for Sustainability Leadership. He works on the interface between research and policy, understanding research on air pollution in rapidly urbanizing African cities such as Kampala, which, as many of you will know, is one of the cities with the worst air pollution record on the continent. Recently, Gabriel has been working with the Cambridge Africa on modelling the impact of electrification on bodas in Kampala to see if there's any impact on air quality there. And that research is going to provide evidence and hopefully recommendations to national programmes and policies to inform decision makers on the effective adaptation and scaling up of interventions in cities. And Gabriel has also been, it'll be no surprise to you, has been a participant in the PATS MECOR programme over time. Gabriel, over to you. Thank you very much.
Thanks for the introduction, and thanks for the invitation. So this is a slide that we shall skip. This, I think, Professor Refiloe's last segment of air pollution is a nice segue to my talk today, which is focused on how do we translate the evidence from research to policy. My name's, I've already been mentioned, Gabriel Okello. My research is focused on addressing air pollution in rapidly urbanizing African cities as a risk factor to health, a risk factor to the recent events, climate change, and the risk factor to environment. And since you're going to be hearing a lot about me the next 20 minutes, I wanted to just get a few volunteers, 1 or 2, to just let me know some of the things that you think you can't live without. Clean water. Excellent. Telephone. Yes. Sorry? Oxygen. Food. Yes, 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 yes. Yes, so we had the phone, we had clean water. Yeah, people are being factual, you know. Some people can't live without a phone for a long time. But I wanted to give you some key facts that every 3 seconds, we take a breath every 3 seconds. We do take over 28,000 breaths per day. And we do take over 10 million breaths per year. And we do take breathing for granted. Sometimes, not all the time, sometimes. When we're sick, we don't take it for granted, but we take breathing for granted. I can guarantee you, if we couldn't breathe in this room for 10 minutes, we'd all be dead. Or most of us, I think, would be dead. So I think breathing is one of the things we can't do without. My research interests really revolve around assessing the impact of air pollution on health, also as a risk factor of environment and climate. How do we integrate this research data into policy and practice? How do we increase awareness about air pollution? And for those on the continent, and also having worked within the continent, I have good news for you. And essentially, these past 5 years have been about working with different stakeholders within academia, but also outside academia, which is always the difficult part. You know, research is always smooth when you're working with fellow academics. Take it to the policymakers and you start going through a few bumps. It's not straightforward. So that is the route, unfortunately, that I took. But we'll see the benefits of it. So I wanted to give a few key facts about air pollution just before we continue. It kills approximately 7 million people a year globally. Around 15-16% of that is occurring in Africa. It's also, as Professor Refiloe just mentioned, straining the health sector by increasing the disease burden. And it is also responsible, according to the World Bank, an economic loss of $8.1 trillion. That's almost 6% of the GDP. So we can't keep pretending that we don't have money to try and find solutions to address air pollution, because there is an economic cost to it. Most of you have worked with policymakers. From my experience, I know 3 things really appeal to them. Money, you know, if you're saving money or the project is generating money. 2, if you're preventing health. And 3, death, because most people, 99% that I've met fear death. So those are 3 key things that really appeal to different policymakers. And I wanted us to reflect on conformity. So recently, for those in the UK, there was a situation with water in a certain part, and we saw people up in arms. And then I saw that the picture below on Sky, where clean water was being delivered to the people in that area, which is rightly so, because you don't want people falling sick. It's strange that air pollution is one of those non-conformities that we can talk about. Oh, Kampala has like 10 times the WHO recommended standard, and the next day we're walking all over the streets. We're not as angry as that. Every product that has non-conformity, there is either a recall or there is absolutely aggressive action. Unfortunately, this is not happening with air pollution, and I think we really need to reflect. And that begs the question, who is responsible? Is it the policymaker? Is it an air quality researcher like me? I think it's upon all of us, because we can't keep striving for sustainability when the air that we are breathing cannot sustain our lives. So I think every one of us should be an ambassador of breathing in clean air, and we should all rise up to this occasion. So back to the research that I undertook, or that I'm still undertaking. It is basically, the approach was to work together with people from different academic disciplines. You know, the group has transport modelers. I hope Dr. Tata is in, or he'll be in at a certain point. Working with people from the pulmonologists, people from the clinic, working with, we also had to bring in policymakers. But how do you go about with such an approach? So the approach was to, how do we address air pollution on the continent where, you know, it's not a big issue in terms of priorities. So I had to first scope air quality management strategies on the continent to try and understand what has been done in different African countries, try and understand what have been the benefits, what have been the unintended consequences, and also how have they been able to go about the different strategies that they have implemented. Then I had to now narrow that down to Uganda, where I was going to start the work in 2 cities, Kampala and Jinja. But within Uganda, I also had to scope, you know, what interventions are taking place. Do the stakeholders know about this? How serious is it on the agenda? Who is doing work within, you know, the air quality monitoring or air quality management landscape? Because I don't want to be like someone who's just coming to prescribe. I didn't want to go and duplicate work that is already ongoing, but I just wanted to build on what is happening within the continent. We had to map the different policies, the different strategies. We had to now bring together different stakeholders within the country to try and understand. Because this is a co-development process, it's a bit tricky because you have the science, but politicians always also have their different agendas. So in the end, we came up with a big consortium having representatives from the Ministry of Transport, Ministry of Environment, Ministry of Health. We had Ministry of Water and Environment, yes. We had Ministry of Energy. And from the academic side, we had a collaboration with Masekela University, where I'm a visiting research fellow, a group at the computer science and a group at chemistry. We had collaborations in Birmingham, as far as a group in Birmingham and a group in the US. And all those had a factor to play. We agreed and discussed on what would a clean Kampala look like, and what do we need to address. So we came up with 3 main factors. One, people were complaining of transport. Transport was a big issue. The borders. Borders are motorcycles, 2-wheelers. West Africa, they are called Okadas. Asia, they are also quite common. So these are really many within the cities, and they are used because of their ease for access within the narrow roads. They are really used within the cities to try and beat the traffic, to try and save time, etc. So we agreed on that as a key issue. Another key issue was the lack of data. You know, stakeholders were complaining, you know, you're talking about this air pollution, but we don't see the data. We're only having one data point, and rightly so. At the time I started, we had one continuous monitor at the US Embassy in Kampala. And I had some monitors which I was using that was 17 monitors, but they were not continuous. I couldn't run them continuously for a year. So they would run for 24, 48 hours, and then I have to come and recalibrate them, and then they run for again another 1 week, 2 weeks, and I recalibrate them. So it was a bit difficult. We partnered with Masekela, that is making low-cost sensors in Africa on the continent. And then we said, okay, we need to close the data gap. Now, with the data that had scoped, we had to discuss this also with the stakeholders in Uganda to try and understand what is happening on the continent. we surprisingly found that 75, we had three intervention categories. One was technology, the other was policy, and the other was behavioral changes. Now we found that 75% of the strategy of the interventions belong to the technology category. But strangely, these were mostly, strangely for someone outside Africa, you know, they'd say, you know, that how come 75% is technology? Where is that coming from? I wasn't surprised because most of those were coming from cooking. So because in Africa, most of the cooking is done using biomass. So these were mostly improved cook stoves. Others, I call them modified cook stoves because when we would measure, they weren't really reducing the air pollution. But strangely, we found that the interventions that were focusing on policy were only 20% and behavior change were only 5%. And the two critical things that you need if you want you know, to sustain an intervention, you need the policy, you need people to change their behavior, because most of these interventions require behavior change. And to us, it was a bit disappointing that you know, the biggest majority of the interventions were not focusing on the policy. Of course, it wasn't surprising that most interventions were focusing on household air pollution as compared to ambient. Though we are seeing the trend change now because of the rapid population growth, the need for people to move around within cities or across cities, that is changing. The other critical thing to notice was only 14% of the studies measured assess the effectiveness. Now, you won't improve an intervention or you won't know how effective it is if you're not assessing the effectiveness. So that was a bit that was a bit also disappointing in a way. But was also an opportunity to try and build on what is already happening on the ground. So we recruited, for the transportation part, we recruited around 50 two-wheeler riders that use petrol. We also recruited, at that time, we had about 100 electric motorbikes in the country. We also recruited 50 of them to try and understand what would be the selling points, because the electric ones were very expensive compared to the ones of petrol. So what would be the selling points to the people who are going to buy these new electric motorcycles? We carried that out with a distribution company, a business logistics company that was using these things for delivery. For those who have heard about Jumia, it's common in Africa. It's like Amazon here, I think I'm not getting that wrong. Jumia is a delivery company that does logistics of delivering goods around the continent. So we partnered with a distributor for Jumia. We also partnered with motorcycle riders to try and understand how much they spend on fuel, how much these guys would spend on charging, the guys who are using electric, etc. And then we had to come up with a briefing for the policy makers to try and inform them the initial evidence that much as, you know, having these electric two-wheelers would be good, these are kind of the challenges. Without incentives, we can't go anywhere, because you know, this technology is really expensive. These people live from hand to mouth. There is no way they are going to spend this money. So you need to have incentives for these people. That is first thing we have to do day one. We can talk about the training, the upscaling of riders, mechanics, the supply chain, etc. But without incentives, we're not going anywhere. And after a long, painful process, the discussions over 18 months, the first, I would say, policy experiment was done in the previous financial year. So the Uganda financial year runs from 1st July to 30th June of every year. So they did, first incentive was removal of import duty on electric bikes. Why that was? To try and make these two-wheelers a bit more affordable for the people who wanted to use them. So when they did that, we saw a rise of importation, a rise of use. Between that time up to, I think, May, we have had about the increase from about 250 electric motorcycles in the country to now almost 2,000. But that is a small number compared to 1.2 million that are in the country. So there is still a long way to go. In the recent budget that has been read out, VAT has now been scrapped on electric vehicles. So this takes the whole electric vehicle supply chain, not only two-wheelers. The stamp duty has been scrapped, and the income tax has been scrapped, and there has been a $10 million promise to the local bus manufacturer. There is a company that is being built to manufacture electric buses in the country. For those who have done research in e-mobility, $10 million is a drop in an ocean, but it's also something that you can use to catalyze and probably raise some private equity funding. So now what we've been doing with support from Cambridge Africa, Corina and team, they added us some money. We want to get the actual numbers. As Professor Refiloe said, it's difficult to convince not only policymakers but also funders if you don't have actual numbers. So the numbers to the air pollution we have, we don't have the economic numbers in terms of if, let's say, the policy was made to allow 30% of the motorcycles change to electric. How would that look like in terms of the government gaining or losing money? That is important. The lives saved, the money saved in terms of the health attributes, the health burden. So that is some of the modeling that is currently taking place. We had a delay with the characterization data. So to characterize this, you need to find, in the normal air pollution data, you need to separate which one is coming from cars, which one is coming from industries, which one is coming from diesel, maybe the diesel cars, which one is coming from generators, so that data delayed. But we are working with a very competent modeling group at the Transport Modeling Group in Cambridge. And we are on our way to try and get that data with the modeling group, but also with the policymakers being informed on whatever is happening. So this multi-stakeholder approach gave a bit of, I would call them spin-off advantages or spin-off interventions that came with it. We managed to finally get the first ever air quality standards for Uganda, where I was leading on the scientific advisory committee. Those were launched in May, and these would really help to guide people, to guide the policymakers on the local limits, on the legal framework, and also there's been a lot of public awareness raising. I'm now also working with the committee on the East African, they call it East African Community Office, to try and get standards for East Africa as a region. Because having standards in Uganda and Kenya and not having standards in other countries is what we call transboundary air pollution. We can't limit air pollution only one area. Air moves freely within across boundaries. So we are working on the East African guidelines. We did work to try and explore what is the impact of air pollution on healthcare facility visits and admission. And we found an association between the times when the air pollution, ambient air pollution, this is the air pollution we're measuring from with devices outdoors. We found an association between that and increase in visits related to asthma and also admissions due to pneumonia. What we also found, there's also an association with meteorological factors, that is the humidity and also the temperature. So we need to kind of get out the noise of what the impact that is being caused by the air pollution alone minus the meteorological factors. And what we're also currently doing is to try and to try and develop early warning tools for the healthcare facilities to inform them that, hey, maybe in the dry season, you expect these cases of asthma or pneumonia, people coming in for visits. And maybe in the wet season, this is what you expect, to try and help them be better prepared in terms of tools, in terms of personnel, etc. This is the platform that I told you about, that I have good news for you. There is a platform that has recently been launched. You can get near real-time data on the continent, over 12 countries on the continent, near real-time data for the cities. For those who are researchers, there is a place to download the data and interrogate it further. This we've done in collaboration with Masekela Airco at the Department of Computer Science. But I think most importantly, as I wind up, what lessons have I learned through this process? One thing I've learned, that research can inform policy. That's a fact. Another fact is that the political community can override your evidence. You might want, okay, let's change this whole street maybe into a non-motorized lane, etc. Politics can override that, but it's good to make them understand the evidence so that you head towards the right direction. There is need for more collaborations with the policymakers. It's time consuming, that's a fact. You need to understand the cultures, the diverse cultures and values of the different communities who you're researching in. Let's avoid trying to just prescribe to them, what we have read from the research papers and journals. You need to understand where they are coming from the knowledge and perspectives we got, that the stakeholders actually had the lived experiences of air pollution, and they actually knew about it. The only thing is that they were confused on how to kind of tackle this challenge, as it was cross-cutting. Someone of health is like, but that is being caused by people of transport. Why doesn't the transport people fix it? Transport people are saying, you know what, but that one is under energy. How can we fix it? So just trying to bring them together, I think, is a good thing. Keep the communication simple. The benefits, as I rush through them quickly, it's a two-way learning. I now have an idea of how policies are made. I'm not an expert, but I understand. I won't go to policymakers and I want something done tomorrow. I will be lying to myself. So I understand the time it takes to try and push some of these things. It's a two-way learning. As they're learning, you're also learning. There's increased awareness, communication, but there are also some challenges, as I mentioned. And this is a call to action for us as researchers and in whatever job that we do. We need to address these systemic risks. They are cutting across, and they are, with the recent floods in Kenya, Professor Refiloe mentioned the air pollution in India. We need to take on these things as a society. Otherwise, we're going to have challenges. Society is as strong as the weakest part. We've seen this with the pandemics, the hoarding of vaccines. We are seeing this with immigration. It's a very, very hot topic. Immigration all over. What we don't want to do is add air pollution as another factor of why people are immigrating from one area to another. We really need to address this. We need to increase the use of research to policy, and also use the knowledge that we have to spark action at strategic level. And finally, I'll leave you with these two graphs to reflect as the next speaker is invited. Those are the numbers that are caused by COVID in the 5 years. This is what air pollution causes every year. Reflect on where you would put more effort. Thank you very much.
So, huge thanks to Gabriel for a really important talk, which was nicely complementary, not just the first one, but I think it was also going to be really complementary to the third in our sequence of three. The third talk, if I can just get out my phone that I rely on, as you now know, and make sure I get the introduction correctly. It's a great pleasure now to introduce, for this third talk, focusing on It Takes a Village, a practical approach to the diagnosis and management of interstitial lung disease. And this is going to be delivered by Dr. Wanjiku Kagima, who's a pulmonologist working at the Kenyatta National Hospital in the Respiratory and Critical Care Unit, where she's currently serving as the head of internal medicine department. She has a PhD in clinical sciences from the London School London School, I beg your pardon. The Liverpool School of Tropical Medicine, it's Nell, isn't it? and a Master's in Respiratory Medicine from the University of South Wales and Master's in Global Health Research from Lancaster University. Dr. Kagima is a Fellow of the East, Central and Southern African College of Physicians, a Fellow of the American Thoracic Society and a member of several other professional bodies. She received a Cambridge Africa Alborada Research Fund Award in 2023 with her Cambridge collaborator Dr. Jenny Dickens, who is based in Addenbrooke's and Papworth Hospitals, to examine how interstitial lung disease can be better diagnosed in Kenya and the true burden of disease can be quantified. She's another graduate of the PATS MECOR programme and this year will be a faculty member for the course. Dr. Kagima, thank you very much.
Thank you for the kind introduction. Let's see whether I can manage to get my slides up. So my talk is basically focused on the work we're doing with Dr. Jenny Dickens that Alborada funded. And this, the topic of my talk is, it takes a village, a practical approach to the recognition, diagnosing, management of interstitial lung disease. It's an honor to present this work to you. Sorry, I was trying to get my way around. So interstitial lung disease is an umbrella term. Really, it includes hundreds of lung diseases under it. And most of these lung diseases either cause fibrosis and or inflammation. And the progressive fibrotic type has a very poor prognosis. The focus of this slide is just basically to show you the different ILDs and the different mixes that inflammation and fibrosis. As you can see on one end, the red end, I think this is a pointer. Does a pointer work? Sorry, I'll use this. So on one end, you see the red fibrotic type, which may respond to your anti-fibrotics. And then you have on the other end, the yellow one, you have the more inflammatory type. And this usually may respond to immunosuppressive or modulatory therapy. So it's a different mix. I think of it like pizza, really. You have this lung disease with lots of different mixes. And sometimes, and honestly, it's really hard to diagnose sometimes. So we know fibrosis is a common endpoint to a lot of lung diseases, including TB, which is very common in our area, sub-Saharan Africa. We have high burden of TB, and it causes fibrosis. So you can imagine how difficult it is to differentiate between ILD, interstitial lung disease, and even post-TB lung disease, and many other diseases that cause fibrosis. So it doesn't have a particular phase to it, and this makes it very hard to diagnose. And another point, when identifying progression of fibrosis, particularly in interstitial lung disease, may have prognostic significance. So it's very important we identify that. So what are the indicators of progressive fibrosis? These are easy said, harder to actually note them, especially when you're teasing out interstitial lung disease from all the other lung diseases. One, worsening respiratory symptoms. You can imagine most lung diseases can cause worsening respiratory symptoms. So you can have increased cough and progressive dyspnea. Secondly, the physiological evidence of progressive disease. So you have patients with worsening lung functions and even worsening diffusing capacity. Thirdly, radiological evidence of progressive disease progression. And this is identified mostly on CT scans. So really, the indicators of progressive fibrosis are if you're not keen to if you don't know how to pick out interstitial lung disease, they can be indicators of multiple other chronic lung diseases. The point of this slide is just to show us, this is a pictorial form of showing the decline in the FVC. This is the lung function. And you can see from the year 2014 to about 2023, you can see the lung function, the restrictive capacity of this patient is slowly going down. And you can only identify it by tracking through the ears. And this patient had interstitial lung disease. Radiologically, this is a coronal scan of a patient in time point A to my left and time point B to my right. And as you note, you see more white opacities in time point B, which means progressive fibrosis. This is a sagittal scan showing the same. To my left again, time point A, and to my right, time point B. And you see the more white opacities, which suggests progressive fibrosis in this patient. So over the years, there have been key clinical trials that have informed the development of the guidelines of ILD. I just want you to note some of them have, like you can see, this is ATS, American Thoracic Society, ERS. And as you go on to the next slide, over the years, you see European consensus, Brazilian guidelines, JRS, you don't see Africa anywhere in this map, and in this clinical guideline. So this is how Africa looks like with regards to interstitial lung disease. I don't have numbers. I don't have numbers at all. So we don't know how much interstitial lung disease there is. And whatever has been published are small in-hospital studies that basically pick a certain type of interstitial lung disease. As I've told you, this is an umbrella term that has over 100 lung diseases under it. And you see the reports that have been reported are mostly on connective tissue-related interstitial lung disease, which is just a small subtype of the ILD. So really, Africa is black or white, as you see it. So what are the limitations we have? The guidelines we have are mostly from the global north in terms of the diagnosis, treatment, and management. Secondly, we know our epidemiology is different, and we have different exposures, as you've been shown by Gabriel. Thirdly, our current guidelines recommend care that may not be feasible on a global scale. It's easy to access a CT scan when you're in the global north. Try Africa. It's easy to access lung function tests, even in a small hospital in the global north. Try Africa. My country, point in case, lung function tests are only available in tertiary referral hospitals. And at the moment, we only have 3 tertiary referral hospitals. You may access them in private hospitals because they have the money and the finances, but majority of Kenyans don't have access to lung function test. It's also very easy to access supplemental oxygen when you're in the global north. Try Africa. Case in point, my country, and I work in a tertiary referral hospital, but we've got patients waiting for home oxygen. We sometimes, more often than not, fill up our wards because we've already sorted the patient's acute problem, but they cannot go home because they don't have home oxygen to go with. So they have to stay in hospital until maybe social support, and some of them die in hospital because we just can't get oxygen for them to go home. And we know the progressive type of interstitial lung disease, patients, the lung function will deteriorate to the level of the patients needing oxygen. And also, the feasibility of multidisciplinary team discussions, which I will talk a little bit more. I also put thoracic surgery there, and also interventional procedures, sometimes in the diagnosis of interstitial lung disease. When the diagnosis cannot be made by a multidisciplinary team discussion, then you need tissue biopsy. and tissue biopsy is usually achieved through either your thoracic surgery or your interventional pulmonology. And also, there is also need to exclude current or prior TB. As I said, most chronic lung diseases will give you fibrosis. So we need to differentiate, is this post-TB lung disease? Is this interstitial lung disease? Or is it something else? And also, I didn't put this point up, but it's been spoken about, competing priorities. Are we going to deal with TB? Are we going to deal with interstitial lung disease? And in terms of policy, will the government put any funds towards interstitial lung disease as opposed to putting funds towards malaria, TB, more common illnesses? This brings me to the project that we got funded for, which is understanding the Kenyan ILD, which is interstitial lung disease epidemiology, and optimizing interstitial lung disease care through establishing a national multidisciplinary team discussion. The purpose of this was to facilitate experts to come together across the country to share insights on diagnosis and management of ILD. Why? As I said, ILD can be complex to diagnose and manage. And we know very well now that multidisciplinary team discussion is the gold standard of diagnosing, and it's been found to have a very high level of diagnostic confidence and also inter-observer agreement. However, that is not always feasible in our countries to have MDTs for all the cases. So who did we invite in these teams? We wanted the pulmonologist, who are the chest physicians. We wanted the rheumatologist because we have the connective tissue type. And then we wanted the radiologist and the pathologist in this team. And how did we do it? Through the Respiratory Society of Kenya, we lobbied for inclusion of the various medical experts into the ILD MDD, and we formed a WhatsApp group to facilitate communication. And out of this, we had the inception of the ILD clinic at the Kenyatta National Hospital, which is our tertiary referral hospital, in August. I'll just tell you a little bit about this. We had to vote to have the clinic start at the hospital, and the hospital has 5 pulmonologists, I remember, and only one was on leave, so the vote was 4. We only voted 2 people towards having the ILD clinic, so it was a 50-50 vote, you know. And the other 2 pulmonologists said they were too busy to run the clinic. So currently the clinic is only run by 2 pulmonologists. That was an uphill task. And then the other part, now we also held the first national MDD in September, and we've been holding them every month thereafter. And this has been a huge success because we started with an audience of about 20, but currently the audience goes as high as 80, which means everybody's seeing the value for these MDDs, the multidisciplinary discussion. And in these meetings, we discuss about 3 to 6 cases per meeting. So we've had collaborations with the Papworth team, thanks to Jenny, and they visited Kenya in April 2024 and met the head of the respiratory department, that's Dr. Nyale. They also had sessions with radiology residents. This is Nick having a session with the radiology residents. And they also had sessions with our radiologists, and one of our radiologists is also here in the audience. This is, that's the Kenyatta National Hospital, which is a tertiary referral hospital. And we also had a symposia where we had an ILD field day, and we had experts from Papworth sharing their experiences and also information on ILD. And this is Jenny and team. We made them into Maasai warriors. And we also held a Sub-Saharan ILD summit just recently. And in this summit, we invited pulmonologists and rheumatologists from Ghana, Nigeria, Kenya, of course, because it was held in Kenya, and also South Africa. So I'm here for the talk today, but also here to visit Papworth. Myself and our radiologist, Maxwell, we are here to visit Papworth, see how they run the ILD clinic, and also attend the ILD preceptorship, which will be happening soon. So what next? We hope to collect and analyze the data, and hopefully to give you a better map than the white map that I showed, so that we know how much ILD do we have, how bad is the disease, and what can we do about it. And then later, we hope that this could go into having an ILD registry in Kenya. I want to acknowledge Cambridge Africa Alborada Research Fund, the Royal Papworth, and Jenny for all the support. I just want to leave you with this, that it takes a village. Thank you.
Well, that was a great way to round up the session on lung disease. So we've had three speakers here this morning, and I'm sure you've all appreciated the real insight that they've given us in terms of the work that they do. And it's a great thing for Cambridge Africa to have these three speakers of such quality talking here this morning. I just want to very quickly start by asking all three to reflect very briefly on how they have benefited from the PATS-MECOR programme. And Gabriel, you've had 10 minutes off now, so I wonder whether I can ask you just to start.
Yeah, I think one of the key benefits for the PATS-MECOR program was going through the 3 stages. PATS-MECOR has level 1, level 2, and level 3, where you learn different methodologies of assessment, but you're also taken through different processes of developing a proposal, collaboration. So I think for me, apart from gaining the technical abilities within the different teams that I was put in, but also the collaborations have been fruitful to an extent that I still collaborate with some of the PATS-MECOR cohorts that I was part of, like in 2018, 2019. So I think for me that's really powerful.
Thank you. Wanjiku, I wonder whether you would add to that at all.
Yeah, apart from collaborations, I also got an opportunity to do my PhD. Thanks to the PATS-MECOR, I formed collaborations with people in the UK and in the US. I also got into leadership. I was a very closed-in person and very shy. And so PATS-MECOR gave me wings to fly, and it's given me a podium to do leadership and also do a lot of research.
Thank you. Refiloe, I'm sure neither of those stories will be news to you, but I wonder whether you'd like to add anything, and then we'll just open the floor for a few questions.
Okay. I think for me, the importance of MECOR is not just the technical bits that people learn, it's actually the networks that they build. I think for me, that is actually the greatest value. And I think for many people, it's given people just that spark of confidence that, you know, despite my limitations, despite the fact that I may not have access to EndNote at my institutions, there's always someone at the end of the line I can call, I can ask, and they'll be able to help. And I think that network of really a family, it's actually a MECOR family. You know, I know that if I'm in Kenya, if I'm in Uganda, if I'm in Ghana, there's always someone that I know in the country because of the network that's built by the program. I think that's probably more important, and for most of the feedback that we get from the students, the most important thing that they get out of it is they just get that idea that I can.
Yeah, that's so important. Thank you all very much. So further questions from the floor? Yeah, there, please.
I have a question.
I think there's a microphone coming if you use
sorry.
it, please.
Really wonderful talks. I really enjoyed it. I have this question. It's for everyone, but mainly for you, Professor Masekela. So yeah, it's really a shame to hear that, you know, there is this rising burden of NCDs, and it's claiming lives, things like asthma, things like COPD, which are easily manageable. But from your talk, I could perceive that it's more of a problem of lack of access to medicines and, you know, ways that could be better patients can have better access to medicines to manage it. Now, my question is, Africa is a huge continent, and from all the talks, there's a huge and strong narrative about Africa not having things that are basic. I understand how that can be, but the question is, there are 54 countries. In your experience, do you think there are some countries that are doing better than others? Because the United Nations SDG Index shows that in achieving SDG 3, good health and well-being, there are countries that are doing so much better. So the metric that they're using, do you see it in real life, or is it something that is just, to put up there? That's one question. Secondly, how are African governments really addressing this? Is there government buy-in in terms of policies that could be created and implemented in terms of creating access to medicine, asthma, inhalers for children, and all of that? Is there any interest more broadly? Are there any movements to create policies and make some noise to say you can actually give people inhalers and create clinics that people can have access to? Thank you.
Thank you. I'll try to tackle it because, of course, you're absolutely right. Africa is not one homogeneous country. We are many countries with many diverse GDPs, diverse access issues, and it's really different depending on where you are. When we actually looked, we've tried to do this in terms of, because one of the things in terms of what you mentioned is access to treatment, access to the most basic asthma care. And in most countries, the drugs may be there, but they're not affordable because many countries do not have universal health coverage. That is actually the biggest challenge, that most people, although drugs may be available, they may be in the pharmacies, people cannot actually afford because a lot of countries, they really require people to have out-of-pocket costs. And another problem is in terms of costs of drugs. I know that there's clear data. If I want to get a combination inhaler in Uganda, it costs 20 times than it does in South Africa. So there's also those procurement chains and how the drugs get from market to the patient's hands. That's very different. And I think that is a conversation that can easily be had at an AU level to ensure that people actually get drugs at the same price. Why should I pay 20 times for the same drug if I'm in Uganda versus when I'm in South Africa? Because that actually increases the access gap. For example, in South Africa, we have universal health coverage. If you are sick, you can go to any hospital and you'll be able to get basic drugs. But the biggest challenge that we've seen, for example, that study that I was talking about by Marie Solbrink, is there's also different costing levels. If you're looking at a government pharmacy, a private pharmacy, and then you have a different pricing level when you go to a hospital level, when we go to a clinic. So I think those things can actually be addressed at a more policy, higher level, at an AU level, so we really level the playing field and stop having these huge discrepancies in terms of how people are accessing these drugs. And in conversations that we've had with the WHO, it's to really see how at a real policy level we can improve access by addressing these things, and also by having at the UN high level meeting discussions about how can we put inhalers in patients' hands like they did with diabetes, which they've done successfully, and that would also address all these procurement, supply chain issues to make the drugs easily affordable. I think it's the only way we'll be able to solve the problem. We can't do it without the policymakers. We really need them on board to be able to do that. But we hope that as PATS, we're part of FIRS, which is the Federation of International Societies. We're lobbying the WHO at the next 2025 meetings to actually make NCDs part of the UN agenda in terms of ensuring that every person should have access to an inhaler in their hands.
Thank you. So we have a question here at the front then.
Yeah, great talk. All mine goes to Gabriel. Gabriel, congratulations for having your evidence getting to policy, but I was moved when you were able to contribute to air quality guidelines, to the national standards. Could you just share how you were able to penetrate the policy space and how you were able to influence to have that those guidelines are approved, I think maybe at parliament level, but also I'm keen to know what more are you doing in terms of ensuring they are implemented or they are executed.
Okay, thank you. Very good question. I think with the national air quality regulations, the start of that conversation was we had a sombering time with the people from the National Environmental Management Authority, who told us that, yes, Gabriel, we have this evidence, but we find it difficult enforcing the evidence. Now, we tried to use the WHO has guidelines, but those are only guidelines. They can't be used for enforcement within a country. And those guidelines, you can't get the WHO guidelines and just replicate them and apply them in the country. So what we did, we had to get the National Environment Authority involved. We have to get the Ministries of Energy, Ministry of, I think, Science and Technology. We had to bring all of them together. And the aim was to try and get a standard, because there is this thing within policymakers. Whenever you bring evidence, like, oh no, that one is from the UK, so you know this is not the UK. That one is from America. The problem with you researchers, you just go and read things online, and then you want to bring it for us here. So, so I've faced that kind of talk before, but I had the evidence, the scoping from the African continent. I'm like, hey guys, Kenya, our neighbors, have some sort of framework they are using. Not the best, but yeah, good. You saw what I did there. Yeah, South Africa, had something already ongoing. They had, regulations that they were following. We're like, yeah, so guys, we need to bring this together. So we formed a WhatsApp group, we formed a working group. We started with first comparing. They're like, okay, bring for us standards from different African countries that you think have them. Then we had to compare with the WHO interim standards. We had a working group that kept on refining the figures that we were giving for the different pollutants. The biggest challenge we faced, I think, was from the Petroleum Authority, because, of course, as most of you who don't know, Uganda just decided a few years ago that they're going to drill some oil. And now those guys had the misconception that we are indirectly coming to undermine their work by putting these standards. They later found out that what the standards that we are discussing would actually help them. It helped them improve the methodologies that they were going to use. Some of them are going to just be burning that gas. We told them, you're burning that gas. These oil refineries are in national parks. Some of them are in a national park. So this is what you're going to cause a hotspot here. You're going to affect some of the areas within those national parks. And it actually helped them change the methodology of they were going to handle with the excess gas. So we had a working group with the different representatives from the ministries, and we used to have meetings every month, which we used to where we used to discuss so far, the evidence that we have collected and how we think it kind of helps. Now, when we had the drafts, it had to go through all government departments. Now that's where the challenges started. Slow to respond, etc. They had to go through the departments. So now we had to bring now those together in one room with their representatives, because we couldn't keep waiting for feedback from these departments. The biggest wait we had actually was for approval through Parliament. That took, I think, 16 months. It kept being knocked back, and then the different policymakers would be there to go and present. Now it's not me as Gabriel. I provide the evidence, and then the permanent secretary presents to the minister, Then the minister goes and presents. Now, at first, I think why we were receiving the knockback was because I think the people who were presenting either had not taken, everything that we told them to. They had not taken all the evidence that we had told them. Then the people they found within Parliament, they have parliamentary committees. There are different committees on environment, etc. And those guys do their research about, policies that are being passed. So the first time our group went, they were knocked back because they couldn't defend some of these numbers with the recommendations that were put in. But 1 year and 2 months later, it was able to pass through Parliament, and then it was sent on to law by the President.
That's quite quick for the UK.
No, so the whole process took about 4 years.
That's quite quick for the UK. So I think we have time just for the gentleman there on the right. We're already eating into coffee break.
One naively assumes that the air quality issues are worse in the mega cities. I wonder if you've yet had any comparison between Jinja and Kampala as to the level and the contributing factors in those two locations.
Yeah, so Kampala is way higher than Jinja. Kampala is about 7 to 8 times the average, the national annual average recommended by the WHO. Jinja is much lower. It's about 2 to 3 times. And that is, if you put the average of Jinja, it's about 2 to 3 times during certain seasons. During certain seasons in the year. That is the dry season, where there's a lot of burning of rubbish when people want to plant their crops. So that comes from the peripheral areas of Jinja. Now Kampala, the most the sources, the most profound sources of air pollution, we have the transport. That is about 25 to 30% contribution to the air pollution. Then we have the industries that are also producing quite a lot. Whereas when you go to Jinja, it's more of the people burning from the outskirts of Jinja that want to grow crops. Then that air moves within Kampala, and also the industrial site. There is a site called Masekela towards the lake, which used to have a lot of factories. So now there are cottage industries there, and they're not being regulated properly. So Kampala has the highest air pollution in Uganda. Jinja, not so much.
I'm afraid that I think we've taken a third of our coffee break up already. I'm going to get in trouble with Corinna and Caroline if I let another question come forward. But I wonder if we could just finish by thanking all three of our speakers very much for